So Aditya, finish us up. What's next? What other targets are important to us in triple negative that are maybe perhaps a little bit more near term?
I think I'll come back to what was said earlier in terms of genotyping. I think if we do genotyping of triple negative breast cancers, a subset of them have activation of the PI3 kinase pathway. And that could either be based on PI3 kinase mutations, or they could have PTEN loss, which is the negative regulator of PI3 kinase. So in this, when this pathway is activated, potentially downstream inhibitors like AKT inhibitors could work in this setting. And that was the rationale for a trial presented at ASCO last year called the LOTUS trial, which looked at patients with metastatic triple negative breast cancer, but required that as a subset analysis that we look at the PI3 kinase pathway alteration. And it was based on IHC. And they found that tumors that had a PI3 kinase pathway that was altered, the addition of an AKT inhibitor, ipasirtib, to a taxane-based regimen improved progression-free survival. And it was a randomized phase 2 trial, so it was not a very big trial, but despite the smaller sample size, it was statistically significant, which talks about the higher effect size that was observed. Interestingly, in that trial, they looked at different methods of looking at PI3 kinase pathway alteration, IHC-based and NGS-based. It was the NGS-based assay that was really predictive of benefit. The IHC was not that predictive. It could be an issue of the specimen or the way it was done, but NGS-based assay was the clear winner. And so now this is being moved into a randomized phase 3 trial, which is a registration trial with this agent called the Ipatunity from the ipasirtib. That's an interesting name. And it's a trial for metastatic triple negative breast cancer, but also metastatic ER positive breast cancer. So this trial has both triple negative and ER positive subsets, and patients would be randomized to receive a taxane versus taxane plus an AKT inhibitor. And if that's positive, that would be another option for our patients with metastatic disease.
And it's at least about 40%, I understand, that by NGS has either lost PTEN or amplified AKT or has a PIK3CA mutation or amplification. I think those are the main alterations that were there, you know, in the triple negatives. That's pretty good. Maybe it'll be even a little more when we screen widely, but maybe it's closer to half of our patients that might be eligible. But yeah, super important because we know when you lose PTEN that AKT is really an active signaling moiety in triple negative breast cancer. So yeah, great trial for patients that are for phase 3 now. But well, thank you guys for a great discussion. And just given the last opportunity, if there's any final thoughts that we have, you know, I guess I'll start and just say I'm looking forward mainly in this year ahead to figuring out how to incorporate the PARP inhibitors into my metastatic population that's just brand new upon us. So I have to kind of figure that out and find those patients and then where exactly do I use, probably early for the triple negatives and after utilization of hormonal therapy and the ER positives. And for me, the other thing I'm just looking forward to is more checkpoint inhibitor data, hopefully a positive registration trial with atezolizumab soon, and then utilizing that first line. You know, how about you, Claudine? Any final thoughts?
I think the ADCs are also fascinating. I mean, I really feel we're at the cusp of being able to do something different for this incredibly high-risk population. And that we're starting to tease something apart. And I think in the next couple of years, we're going to start to have many more options available to us. We're going to have to, for those of us who are sort of older, we're going to relearn our molecular biology and immunology, which is great. It'll keep us younger. And I think we'll have many more options to offer our patients. Sure.
I think we're going to end up having to change the name of triple negative breast cancer, right? You're going to have to rechange the program title. Because as you started this whole conversation, it really is not about what it's lacking, but now as we identify these biomarkers, you're immediately going to meet a woman with advanced disease and really define it by what's driving the cancer. And serially, that may change. So what we didn't even begin to touch on is hopefully moving to the point of having cell-free DNA and assays where we can monitor the changes in a tumor without having to require such invasive procedures.
Good point. You've done a lot of that work already, Aditya. Yeah. Any final thoughts?
I would agree. I think, we've called this triple negative, but over time we'll find various positives in this triple negative with these targets and targeted therapies. So, and if you think about it, in lung cancer, we don't call tumors that are ALK negative or EGFR negative as triple negative lung cancer. So I think we just have to identify the targets, use therapies based on that, and the future is going to change. So I'm very excited. Yeah. I think, it might be a story similar to HER2 where, if you find something and you have an agent, you actually want to have that subtype of breast cancer. And maybe with these ADCs and with PARP inhibitors, it'll just change.
We are a group of optimists.
Yeah,
we're oncologists. Right, that's why we're oncologists. Well, thank you very much for joining us, and hopefully you found this peer exchange very useful and informative. I certainly have. Thank you all very much. Thank you.
Thank you.